Just as a reminder, we'll be streaming this on YouTube via CTDSS channel, and actually we may also be on CTN possibly, though I'm not sure if that's officially happening today, but just FYI.
Brad, could you enable screen sharing before we get started? Thank you.
Should be all set, Tiffany. Let me know if it's still a problem.
Great. Is that working for you, Tiffany? Wonderful. Brad, Fatmata, anything you'd like to kick us off with before we dive in?
Defer to Fatmata, if you'd like to say anything.
I'll just like to say good morning and welcome everyone to yet another meeting. Thank you for all the work that you have done with us so far. And Brad?
No, I'm just excited to keep having these conversations, so appreciate it. And thanks to the Faulkner team for helping DSS keep this going.
So thanks for coming back, everyone. I think we have a couple of meatier topics to engage in today. So I know this group has met before, so I don't think we need to do live introductions, but if you'd like to introduce yourself via chat during this session, by all means, welcome the engagement. I think today we'll provide some overall updates on the process and just a recap of the feedback that we heard from our last session on quality measures, and then want to spend most of our time talking about recommendations from a subgroup of this committee that talked through newborn and postpartum care details, and then also spend some time talking about inclusion-exclusion criteria for members and providers within the context of defining the bundle. So next slide. Great. So just a reminder of where we are in the overall arc of this work together. So far, we've heard feedback on doula integration and how we can feature doulas within this bundled payment program, as well as spent a good bit of time talking about key outcome measures and measures of success that DSS will use to assess the overall program, and dove deep into a health equity framework to make sure that we're applying a health equity lens to each of the design elements along the way, and have gotten some initial feedback on quality measures, and some additional conversations about quality are still upcoming. So our goal for today is to spend some time talking about some of the key building blocks for the bundle. And by that we mean things like which components of the bundle are, which components of maternity care are included within the bundle, and how do we think about which actual episodes of care are also included in the bundle. In future sessions of this group, we'll dive deeper into the specific services that are included within the bundle. So not just at the postpartum care definition broadly, but sort of double clicking on that to talk in more detail about what's in prenatal care, what's in postpartum care, what's in the labor and delivery services. We'll also dive deeper into the payment methodology. We'll revisit quality measures and pull it all together as a final program design. So any questions about where we're going before we dive into today's work? Great. So wanted to just recap what we think we heard from this group during the last session. If there are other key takeaways that you want to make sure we capture, welcome that feedback either live or following this session. So our colleagues from Yale presented additional measures for consideration that are not part of the standard maternity bundle payment measure set that is used in the state employee health plan. Those include breastfeeding support, the contraception interconception counseling measure, a dual utilization measure, and a patient experience measure. Things that we heard across the board include making sure that everything is reported stratified by race, ethnicity, to the extent that we can make sure that we have that data available. The codes for quality measures themselves will be released in the future and part of a future working session around the technical specifications, that we would look to make sure that they're compatible with the current EHRs in use, and that we recognize that community health workers will be an important part of achieving quality measures. On the specific measures, we heard that it's important to make sure we improve the way in which data is collected for breastfeeding and reported in a meaningful way, and that that it's important to incentivize higher rates of breastfeeding. And so that when we think about how quality measures tie to payment, that might be one that would be important to tie to bonus structure early. That the contraception measure is important for improving access and increasing access to the service, and that in general across these measures that it's important to take the choice and preference of the member into consideration. I think, let's see, the patient experience, I know we heard a lot of feedback around that as well. And particularly some great feedback about ways in which to look at experience of discrimination and racism and disrespect as part of this overall process. Let me just pause there and see if there's anything else that folks who participated in the last session would have expected to see on this and don't, or you've had thoughts about what we talked about last time since we met and would like to share now.
This is Mark from CHA, and apologize if this is elsewhere in the quality measure set, but because it's health equity related. Do you have an SIOH or SDOH screening measure?
That is a great question. I don't believe it's currently on the list considered, but we could add it to the hopper for consideration.
Thank you.
Right, so next slide, Tiffany. So we want to spend a little bit of time recapping feedback about the newborn and postpartum components of a maternity bundle. To put that in context, we're wanted to first share this visual for thinking about the overall maternity bundle payment program. So just as a reminder, when we think about the maternity bundle payment program, it includes the services that would be provided during pregnancy. That's the teal on the left side of this screen. The services that are provided during delivery, whether that's delivery is vaginal or a C-section, and then services that happen postpartum for the birthing person, as well as services that are provided to the newborn following delivery. So we'll talk about this in more detail on the next page, but the sort of overarching takeaway was that when this program is launched by DSS, it would include the teal pregnancy bar, the orange delivery, and the green postpartum period, where the team is recommending a 90-day look back for postpartum for counting the services within the first 90 days. And for the newborn portion, that it would be reporting only, at least for the first year. So next, thank you. So with a provider subgroup of this committee, we spent some time digging into the details of newborn care and postpartum care. On the newborn side, there was a sort of robust discussion about the importance of incorporating newborns into this overall program to make sure that we are clearly tying the impact of prenatal care and care throughout the pregnancy and labor and delivery period to the newborn outcomes, including but not limited to NICU utilization. But there was also recognition that operationally there remain some challenges around matching the baby's and the birthing person's records, and on sort of just understanding what those services are and what it would mean to have accountability for those services. So the overall recommendation would be that at least in year one, newborn care utilization and claims would be included in provider reporting for the performance on the bundle, but that the newborn care would not be part of the financial accountability for providers in at least the first year of DSS's program, though DSS would aim to phase in a financial accountability for newborn care sort of shortly thereafter. Let me pause there and ask both for those who participated in that conversation, if there's anything else that you would add to the summary. For those who did not, if you have any comments or feedback about this proposed recommendation, welcome them. I don't see anyone jumping in. Oh,
Sorry, this is Amy. I have just one note that with newborn outcomes, stratifying by race and ethnicity brings up new issues and needs to be. So I think ideally we would have data for both the birthing person and the newborn, or the newborn's the other parent. So I don't know, but I just wanted to call out that the issues around race ethnicity reporting have like a new level of complexity when you get to the newborn, but we should strive to be able to stratify this.
thank you. Yes.
This is Mark with a question.
Yes.
So I understand the conversation hasn't evolved this far, but had a question about the postpartum care and the need to define exclusion criteria to guardrail against non-maternity adverse health events. So during that 90 days, an appendectomy probably would be a non-maternal health adverse event anyway, which would not be considered probably from a quality perspective or from a cost perspective, that is considering what should have been paid for in the bundle. How do you think about things like postpartum depression admissions? So postpartum depression screening presumably will be an expectation of the providers. And if you identify depression, to ensure that there's follow-up care. Do you see that? So depression can be a pregnancy-related or delivery-related complication. Do you see the costs of a psychiatric hospitalization related to the depression as something that would be part of the bundle or outside of the bundle? And simply perhaps factored into the quality assessment?
So that is a great question. And I think if you'll allow me, I will defer an actual response to that until the next session when we talk about the services in more detail. I want to check with the technical vendor to just understand one way in which to operationalize that is to sort of account for what the expected utilization is and price that into a bundle benchmark. The other way to account for it is to exclude it, and they might have a third way to deal with it. So let me take that one back.
Thanks.
I think there are other avenues for treatment as well, telehealth, et cetera, and, care coordination. So I think those also have to be factored in because a good number of our women are receiving those services as well. And, whether or not those are in the bundle, I think are important.
Just for one quick thing, unrelated, just when speaking, just if you don't mind, just quickly saying your name so everyone knows, especially since we're on YouTube TV. And,
My apologies, Paula Greenberg from Women's Health.
no problem. Thank you.
Thank you. And so we can talk about postpartum care next. Thank you for bringing that up. Just double checking if anyone had any other feedback on the newborn care component before we talk about postpartum.
Can I just jump in and ask a clarifying question? This is Chris Morosky from UConn. And under the providers that are all listed here, particularly the newborn, are we also talking about newborn reporting, provider reporting, inclusive of the sort of obstetrics delivery provider separately? Does this include the NICU provider? I'm just trying to clarify who all the different providers are that are included in both aspects of the provider reporting and financial accountability on both sides of the slide. Thanks.
Great. So in general, when we're using the word provider in this context, it's about the provider who is accountable for the bundle. And so what we're saying on the newborn care side is that at least in year one of the program, whatever OB or midwife or provider that is accountable for the overall bundle would receive data about the newborn as well, so that you have a window into understanding the newborn care utilization and outcomes of the birthing people that are in your care. Great. So on the postpartum side, we also had a robust discussion around what does the postpartum period look like? Should it be extended beyond 60 days, which is Connecticut State Employee Health Plan's current definition of postpartum, and how do we think about who is accountable for that care once you start extending it substantially beyond 60 days. And so we talked about a few different options, including leaving it at the 60-day period, expanding it to 90 days, or even considering expanding it to a full year post delivery. The recommendation is that in year one, we would go with the 90-day definition for the purposes of financial accountability. I think one of the folks brought up several great points in support of the 90-day approach. In particular, we heard a lot about the impact of breastfeeding at between 60 and 90 days and how there's some important transitions in that period that impact the longevity of breastfeeding and the focus that 90 days could help to improve that measure. We also talked about how there is interest in considering looking at a postpartum period that is much longer, up to a year, but that once you go much beyond 90 days, you're starting to look at utilization that becomes more and more questionable about how much is tied to the pregnancy and how much is just standard healthcare utilization, regardless of a pregnancy event. And so the recommendation is to, as part of the program evaluation, DSS will look at 365 days postpartum for all of the birthing people included in this program to just understand what those utilization patterns look like and what it might mean to incorporate that longer term. But for the purposes of the program, at least in the short term, it would focus just on 90 days postpartum. Let me pause there and see if anyone wanted to add anything or have questions or comments about this recommendation. Okay. So as always, if you think of things following this session, you're always welcome to reach out. Can you go to the next one, Tiffany? Thanks. So the last piece that we wanted to get this group's feedback and input on are the inclusion and exclusion criteria used to define the universe of who is covered by this bundled payment program. And so what we did is work with the analytics folks to figure out what are typical reasons that births would be excluded from the program, and what would be reasons that providers who provide OB and midwifery care would be excluded from the program. And then in the context of those criteria, what impact would that have on the program size? So typically, what we see in bundled payment programs is that for maternity care, they would exclude very young cases and much older cases. So I think in this case, we looked at excluding cases for birthing people less than 12 and older than 55. In the DSS data set, that's 0. Also typically they look at excluding cases that don't have a facility claim associated with it. In the DSS data, that is also 0. So seems mostly not applicable, despite that being a criteria used in the commercial or private health insurance space. The other exclusion would be stillborn or multiple births. So we would say that this program would really be defined as the universe of singleton births. What we see in the DSS data for that is that excludes 3% of the total episodes. And then the last piece that we would look at around exclusions is if there are significant enrollment gaps in coverage that would impact the ability to understand utilization of the episode. Here, I think there's some work to do to define what the technical definition of the enrollment gap would be. But I think in general, what we're seeing is that when enrollment gap logic is applied in the state employee health plan or in other commercial spaces, there's it historically sees less than 5% of cases excluded for those reasons. There's no reason to believe that DSS would be an outlier in that case. So that's the logic or thought process around what members would fall out of this program. From there, there's also a logic around what providers would not be eligible for this program. And what we looked at there was typically programs like this would use a threshold between 20 and 30 to say that you have to have at least 20 or 30 births per year in order to have sufficient volume to participate in the bundled payment program. When we look at the experience of DSS providers in this space, it looked as though less than 2% of cases are or less than 2% of births are with providers who have fewer than 30 births per year. So again, that would be a pretty small subset of cases that would end up getting excluded. So let me pause there. That was a lot of information, and see if folks have questions or initial reactions.
Hi, Angela. This is Kara Farrell from Women's Health. I don't know if this is covered on a subsequent page because it technically wouldn't fall into provider or a member inclusion or exclusion. But is there anything that would exclude, outlier cases? So, for example, if a member goes into labor at 28 weeks or 26 weeks, and the baby's in the NICU, so on and so forth, and it turns out to be an extreme circumstance, is there a provision for that?
Yeah, I think so. There's a few things that will need to be discussed, I think, a little bit further. It came with the provider subgroup is, are there further exclusions? We've kind of tried to initially, at least in our initial designs, focus more on a financial proxy of risk. But it's a great question. I think something we'll have to kind of talk a little bit more about. Angela, do you want to, anything else you want to add on that?
Yeah, I think what's not reflected here, and we'll talk about in the financial methodology component, so not a next slide for today, but a future session, is there's some statistical methods used to smooth the overall approach that results in excluding extreme outlier cases. And so I've noted as a takeaway to go make sure we know exactly what that is to feed back to you.
Yeah, and financial, and basically just to explain a little bit more in terms of that approach. So it's a financial proxy for outliers. So for example, there's certain cases that are very extreme in terms of cost for various reasons. And obviously, if you have an early birth and someone's in the NICU for months, there's opportunity to kind of exclude those cases from the bundle. So it's really using a financial proxy instead of a clinical proxy, which means, if you have like someone's care, which may understandably be in the hundreds of thousands of dollars, that case would likely be excluded from the bundle in that case, instead of using specific diagnosis codes. So it's a related but slightly different way of doing that. But we'll be talking about that in the future.
Thank you.
It's Paula Greenberg again. I was just questioning the under 30 delivery per provider, only because we have some large coverage groups. So our providers may be doing more office-based OB and then have a hospitalist arrangement or some kind of call coverage arrangement where they may not be hitting the 30 provider delivery. But the group in itself, when you look at their totality of Medicaid deliveries, may exceed that. So is there any way that there's going to be some scrubbing of that to allow more cases into the episode? I'd hate to exclude them based on that.
And I thank you for that question. I should have been more precise. In the threshold analysis, we did it at the practice level. So at the tax ID level,
Perfect.
not at
Okay.
the individual.
Okay, perfect. Thank you.
So Marcus.
Oh, go ahead, Mark. Sorry.
No, go ahead, Brett.
I was just going to say briefly that the 30 bursts per year that's something we'll take another look at some point, but that's kind of our initial kind of what a lot of bundles have used as the minimum threshold, but that is something that can also be slightly adjusted up or down. I'm not sure we're going to want to drastically, but just to call that out, that there may be a desire to look at that again. Sorry, Mark.
No problem. Thanks, Brad. So with regard to member exclusion, is there a point in time where they present for prenatal care that is too late in the pregnancy to include them? Is that covered elsewhere?
So I think there is some discussion about this still in terms of when is enrollment too late, if there is one, and so that's, I think, a TBD based off of our existing conversations. But Angela, please correct me there if I'm wrong.
No, that's spot on. Thanks, Brad.
Understandably, it's a really important point. Like if you have someone that shows up at 40 weeks and hasn't had any care and is now going to deliver, is that someone we want to include in a bundle? The answer is probably not. But what is that threshold by which you would expect that? And so that's up for, I think, some discussion on this in terms of when individuals are starting to engage in prenatal care.
So one consideration is not to create an incentive to not accept patients into prenatal care because the timing of getting to prenatal care is so late that you don't believe you can have meaningful impact on outcomes. So I appreciate that the importance of having the favorable incentives work for as many Medicaid births as possible, balanced against not wanting to create a disincentive to access.
Yeah, definitely that tension, and want to get it people from wanting to see Medicaid members who are presenting later on. And so at some point, again, switching out of a model like this. Luckily, it looks like the numbers are probably going to be quite low, but obviously we need to make sure we have figured out those outlier cases so that we can make sure that those individuals still can get the care they need when it does occur.
Hi, this is Jessica with Full Circle Doulas. I just had a quick question on the minimum 30 births per year in terms of providers. In terms of integrating doula care in the Medicaid field, being that that really hasn't happened before, is this going to be based on doulas working directly with providers or doulas being their own independent companies having that many births? Could you shed some light on that?
So I'll let Fatmata talk in more detail about the doula integration vision. Just to clarify, for this minimum threshold, it's about the financial accountability component, which is specific to the OB or the midwife, not the doula. So we're not saying here that doulas who are participating in fewer than 30 births couldn't participate in the program. I want to make sure that that's not clear. Famana, do you want to provide some more color?
Yes, thanks, Angela. And Jessica, thanks for your question. I would say firstly that we are still working on how the doula participation is going to look like, but our goal is for doula integration. The doulas will be a part of the bundle, and we're hoping that they will work with the managers of that bundle, whether it is the OB, whether it is the nurse midwife, because our hope is to improve outcomes for members, and we believe that the integrated care will lead to that, but the specifics to that is still being worked through. And at a later point, during the year, we will bring the work around doula integration to you all. Brad, do you have anything to add to that?
No, that was great. Thank you. One quick thing I just wanted to point out, and I was just answer Chris's comment, which I think was responsive, that the 30 births per year cutoff is high. And so again, this is kind of our initial look at it, and it excludes only less than 2% of cases. So it's a pretty small number at that level, but I think it's worth looking at, as we said that 20, again, at the provider level, at the practice level, not necessarily at the provider level. And so it looks like it probably would capture most cases, but it's obviously important to think about, do we slide it up or down a little bit? I think from the DSS perspective, we very much hope that this will drive improved outcomes and so in care. And so the more people we can include, the better. Also recognizing if you only have one Medicaid birth and the rest are other folks that aren't on a bundle, are you really going to be able to provide that service? As a provider myself, you're often pulled in multiple directions. And if you're getting paid in one very different way, that's a big challenge too. So I think we want to be mindful of that, but very much appreciate the commentary and something we will be considering.
Yeah. And I think maybe an additional next step is we can go back and look at which practices are represented by those less than 2% of births, so that to your point, we're appropriately thinking about an equity lens in rural communities and such. All right. So let's see, I'm not seeing anyone else jump in. So, as always, if you have additional thoughts or feedback outside the bounds of this meeting, don't hesitate to reach out. If we go to the next slide, Tiffany. So just thinking about next steps for this group, I know we talked about it at a high level at the beginning. We will continue to have some focused provider deep dives in the coming weeks. Those are represented by the green bars, where we try to dive really deep into a topic and then bring back a recommendation to this group, similar to how we did the postpartum and newborn care work today. So the next session of this group is on September 20th, when we'll talk more about the services included in the bundle, and address some of the, look at specific services within pregnancy, delivery, and postpartum care that are included and not included as part of the financial accountability piece. And we'll meet with the provider group to talk about that, as well as the definition of the actionable adverse event piece that has been raised around this table and others as well. So I think with that, we have completed our agenda for the day. Anything else folks want to offer before we conclude? As always, we're very grateful for your insights and perspectives on this. It will really help make the program much better based on your feedback and input.
Agreed. I was just going to add, a lot of your comments that you're making, as well as in the subcommittees, we take very seriously. We review them. We are still spending time trying to, when we can, when there's alignment, to address them in meaningful ways. And we'll make sure to bring that back when we are able to this group to share. So again, just thanking everyone for their time. We know very, very busy. A lot of folks are joining us and bringing a lot of expertise, whether from the provider space, the community space, the doula space, new CHWs, from various expertise from hospital consultants. I'm sure I'm missing a few folks, but just to say, we just appreciate it and very much welcome your continued engagement here. It's extremely important to us to make sure that this will be imperfect. We know this. There are limitations to it. We want to do the best we can. And obviously there's going to be trade-offs here and there, but we very much do want to be responsive and continue to be responsive as much as possible to improve the health and well-being of birthing people in Connecticut. So again, thank you on behalf of DSS. And Bob, I don't know if you want to add anything else.
Brad, I just want to concur everything that you have said. We really take this seriously, and we want to thank every single one of you for your participation and your contributions, as well as thanks to Angela and team for helping us move this forward. Thanks, everyone.
Thank you all.
Thank you.
Thank you.